I was asking, we were talking with Roland that who is going to co-discuss with you, David, today.
Uh, I think I'll let me see. I talked to someone else, but I think anyone can. So I believe we can. So it's just because our time is limited, but otherwise, I think even three people could do. So we'll see. Maybe I'll discuss with. In case the other one who promised to discuss today doesn't show up, maybe Roland can also chip in and discuss.
Sure. So, David, I think
So yeah, I think it's already time.
mm,
Yeah, I think it's already time. So we should start, and maybe others who are coming will join us as we proceed.
so. Who is the co-discussant?
Okay, let me see if I think is not here already. So the co-discussant was supposed to be Michael.
Oh,
He, of course, he told me, yeah, that he he was expecting, he was having an appointment, but he was hoping to finish
okay.
before we start the session. So yeah, so
So I think you can go with Roland.
because I did not, yeah, so because I did not prepare Roland, maybe if Roland you are comfortable to go, I think we can discuss together. Otherwise, uh, next weekend we'll have Seba. Next weekend, I think whoever discusses will be co-discussing with Seba. Seba was having some other commitments today, but he has volunteered to discuss next weekend. So maybe I'll just offer now this is on a voluntary basis. Anyone who wishes to go discuss with me today, because this is the very first time we do this. If anyone is interested, if not, maybe because I did not prepare, because among the people who have come in, I did not prepare them psychologically. I believe that is also a thing for first timers. Maybe we can just start, and if Michael comes in, we can co-discuss on the next reports. So maybe we can just start.
Okay. So, yeah, we have a 61-year-old male who presented with easy fatigue.
Yeah, so easy fatigue is, I think this is not the first time we discuss easy fatigue. Uh, so for those who have been here for quite some time, I believe one of the sessions we had on easy fatigue is on YouTube, and if you had a chance to follow that, I think we've discussed it several times. So because this is a very broad complaint, I think I will not spend a lot of time on it. Uh, Maybe I'll just mention a few possibilities, and then we'll proceed and hear the HPI, and then after the HPI, I think I can discuss on it further. But easy fatigue is a very broad complaint, and if I was clerking a patient and they have two complaints, let's say they have easy fatigue and then they had another complaint. that is more specific to a system, I would actually go with the other complaint because it will have a bigger yield and maybe more specific. Because with easy fatigue, it can come with anything. So, for example, with the cardiovascular system, uh, someone can come with easy fatigue. For example, someone who has heart failure, they'll have easy fatigue because if the heart is not pumping well, uh, so even the perfusion of the different organ systems, of course, including the muscles, will not be that adequate. But again, someone with anemia will present with easy fatigue. So many endocrine abnormalities can present with easy fatigue. So, for example, someone with hypothyroidism, someone with adrenal insufficiency. So those are just a few examples. Easy fatigue, of course, you cannot pin it down to a specific organ system until you have another more cardinal sign or symptom, which you can Venn diagram with the easy fatigue in order to at least narrow down your list of differentials. So let's see at the HPA, and then maybe I can make some progress.
Sure. So let's go to the HPI. Yeah. So 4 days ago, he noticed he was having easy fatigue when he tried to walk a short distance. It was associated with dizziness when rising from a sitting position and awareness of heartbeat and headache. He also reports fever and night sweat over the same time period. And I reports one episode of non-bloody, non-bilious emesis, but he denies abdominal pain, diarrhea, melena stool, constipation, bleeding gums, skin rash, or shortness of breath. If you have other system on genitourinary system, he has lower urinary tract symptoms, respiratory and neuro, nothing significant. Past medical history, he has a benign prostate enlargement. Meds, he's on tamsulosin and finasteride. And family and social history, he drinks heavily. He takes local brew when he's out of cash, relative reports. And he also smokes half a pack of cigarettes per day for the past 30 years.
Well, this is the first time Joseph presents all these components of the HPA in one. So what that tells me is that we probably have a long way to go today. But starting with the complaint, just like I said before, easy fatigue is very broad and non-specific. But coming to the HPI, the symptoms are rather acute. It's a 4 days history of easy fatigue. So starting with this duration, so when I hear 4 days, so that is an acute onset of these symptoms. So it could be truly acute, meaning whichever process that brought about these symptoms started in a short while, that is within the time period we are talking about of 4 days or maybe a little more. Or another thing is it could be that this patient or the underlying process has been there for a while, but then the manifestations that we see have started showing up just a few days ago. So, yeah, many times I think the time period or the cause of the illness is very informative in terms of the duration. But it's also, I think it's also important to be prudent and think about the other possibilities that maybe what we think of as acute can be something that started a long time ago. Maybe we are dealing with a chronic process presenting with acute manifestations. So, with that in mind, now we are talking about easy fatigue, and then there is dizziness when rising from a sitting position. There is awareness of heartbeat and headache. So anemia was one of the things that I mentioned, but the symptoms that we are talking about here not necessarily because of anemia. So The second bullet for me translates into orthostasis. The patient is having dizziness when rising from a sitting position. And so awareness of heartbeat again, of course, now this awareness of heartbeat, not very specific here, that whether it's present all the time or present when he rises from a sitting position. But dizziness when rising from a sitting position and palpitations, they are symptoms of orthostasis. And so someone can have these symptoms from anything like, for example, anemia, from acute blood loss, for example. They can have features of orthostasis. So basically, when someone has volume depletion, or when someone has autonomic dysfunction, they will have features of orthostasis, like this patient. So I think with the symptoms that we have here, I'm thinking about the possibility of volume depletion, but that one is not indicated by the other symptoms. So just one episode of vomiting, that's not enough. Maybe if it was very severe, to cause volume depletion that is significant enough to lead to orthostatic hypotension. Otherwise, diarrhea, again, we are told there is no history of diarrhea. So another thing is acute blood loss. Now, where exactly is this acute blood loss? There is no hematemesis, and there is no diarrhea, there is no melena. So maybe this patient is not losing blood, whether through the upper GI or the lower GI. Maybe if we are talking of something else, like if someone is having internal bleeding. So anemia is a possibility in this patient, but another possibility is based on the past medication history. So this patient is on finasteride and tamsulosin. So tamsulosin is an adrenergic antagonist, and these medications are known to cause dizziness. So they can cause symptoms which are very similar to orthostatic hypotension. So that's for the dizziness itself, tamsulosin can be implicated. But then this patient has a constellation of symptoms. We are talking about easy fatigue, we are talking about dizziness, and then palpitations, as well as a headache. So I'm considering a possibility of anemia in this patient. But again, this patient is having fevers and night sweats over the same time period, which is 4 days. So there are symptoms of inflammation in this patient: fevers, night sweats. These are uh, they are they are constitutional symptoms. And when I think about this, when I think about fever, I have that favorite mnemonic of IMAID. So for this particular patient, I think I'll need to prioritize this. So for IMAID, I'm talking about infections, which I need to prioritize in this patient. And then malignancy, of course, with his history of his history of smoking, and then the alcohol also. I think some malignancies are also under consideration, although the time course of 4 days is not in keeping with malignancies. Then autoimmune disease, we do not see anything that is in keeping with that. Drugs, so this patient is on tamsulosin and finasteride. So for drugs, you talk of things like DRESS and many other things, maybe not a very huge possibility. Endocrine abnormalities, I do not see anything that is pointing me in that direction. So I think I have to prioritize infections in this patient. Infections, and then of course I'll keep those other things under the radar. But otherwise, I think I'll have to prioritize infections. Now, with this acute presentation, 4 days history, there is fever, there is night sweats, and then the patient is also presenting with easy fatigue, features of orthostasis. So something that I'm inclined to think maybe I'm dealing with anemia. So I think also infections, so something like malaria, for example, that can explain fevers, maybe not so much the night sweats, But if there is hemolysis for malaria, of course, someone can have anemia, and the anemia can present with the symptoms we are talking about in this patient. So I think I think I still haven't made much of progress, at least from the HPI, but I'll see as we progress. I think this time with physical examination, I'll see. Now, can I just take me quickly through? Yes, so the patient has lower urinary tract symptoms. I'm just curious, are we talking about obstructive loops, or is it irritative? Obstructive meaning frequency, for example, uh, straining, or are we talking about irritative symptoms, painful urination, urgency? What exactly are we talking about?
Both of them.
Okay, so uh, now since we are considering a possibility of, we've talked about infections, I still haven't found a better match for to explain all these symptoms. But of course, someone with BPH, so because of the obstructive symptoms, that can be a very good culture media for bacteria. So someone is having a lower urinary tract infection, and that can spill over to involve the upper urinary tract, including pyelonephritis, for example, all the way to full-blown sepsis. So all these are a possibility. I think I should also entertain that possibility, although now that does not explain anemia, at least, or symptoms of anemia, which again, I haven't concluded that we are dealing with anemia. It could be anything: volume depletion, acute blood loss, or we are dealing with autonomic dysfunctions. All those are possibilities, but I think that adds something else. And then no symptoms coming out of the respiratory system or out of the CNS. Can I see the next slide? Okay, so I've already discussed about the benign prostate enlargement. Next, yes, I've also talked about this. And then next, okay, so drinking and then smoking. I think I've touched a little bit on these. Now let's proceed to physical exam, uh, so I can see if I can make some progress.
Sure, that's a good start. And so, general exam, patient was alert and oriented. He was febrile, pale, was not jaundice, no lymphadenopathy, and no lower limb edema. His vitals, blood pressure normal, pulse rate high, 112. Let me admit someone here before I proceed. Yep. So also tachypnic at 24, febrile at 38.4, but saturating normally in Lumea. Systemic exam, per abdomen was normal. Other systems also normal.
Okay, so the physical examination again, I think with the vitals, so I talked about a possibility of hemolysis. Now, considering a possibility, maybe if you are dealing with malaria, for example, severe malaria leading to hemolysis can present with those symptoms, but with that kind of massive hemolysis, maybe we would see the patient would at least be jaundiced. So although that does not make me completely throw out that possibility, but coming to the vitals, the patient is febrile and then tachycardic. So that is not a surprise. If someone is febrile, we expect the pulse rate to increase. And because we have a new audience every day, maybe I should just spend I should repeat what I've said a number of times. So uh, commonly, what has been observed is if you have a 1 degree rise, a 1 degree Celsius increase in temperature, you expect a 15 to 20 beats per minute increase in pulse rate. So tachypnea is not a surprise, but tachycardia is not a surprise. But the tachycardia could be explained by a number of things. So the fever could explain it, but then again, this patient is having easy fatigue, is having headaches, is having awareness of heartbeat, is having dizziness in rising from a sitting position. So the tachycardia could be an adaptation to the fever, or it could be an adaptation to whatever process is going on, whether it's anemia, whether it's volume depletion. So either way, all those could be a possibility to explain this tachycardia. Tachypnea, of course, again, when someone is febrile, they might be tachypnic. But again, uh, so we did not see anything coming out of the respiratory system, no cough, no difficulty in breathing. But this patient is tachypnic. So uh, I think this has to be explained. Although physical exam, respiratory exam is non-revealing, nothing coming out of the respiratory system, anything like crackles or any abnormalities in the breath sounds or percussion note. So the tachypnea that we see maybe may not be 100% explained by a primary pathology in the respiratory system, but by a systemic process that is going on in this patient, leading to an adaptation of tachypnea. So I think that's all I have for the vitals. Again, I would expect the physical examination, especially systemic exam, at least to have some clues that can help me pin down these symptoms that I've been discussing so far, in order to see maybe where I can localize what we are dealing with. So, okay, can let's just proceed to the labs so I can see if I can make any progress.
Yeah, a lot of folk have joined. Can you give them a summary?
Okay, so Joseph has been presenting. Can you remind me the age of the patient?
61 male.
Okay, so this is a 61 years old male who presented with a 4 days history of easy fatigue associated with dizziness on rising from a sitting position, uh, awareness of heartbeat and headache, but also associated with fever and night sweats of the same duration, 4 days. And the patient had one episode of non-bloody emesis, and he also has lower urinary tract symptoms, both irritative as well as obstructive. He's a known patient with BPH on finasteride and tamsulosin. He drinks alcohol heavily, including local brews, and he also smokes half a pack of cigarettes for the past 30 years. On physical exam, so the abnormalities that we have are tachypnea, tachycardia, as well as fever. Otherwise, systemic examination was normal.
That's a pretty nice summary. So let's go and see the labs. CBC white count was normal. HB severe anemia 6.1. This guy attended at the same hospital 2 weeks ago, and they did a FUBA picture. Luckily, on that visit, and his HB 2 weeks ago was 10. MCV was normal at 84. Platelets thrombocytopenia of 32. The CBC of 2 weeks ago, it showed 233. So these things occurred in between here. Creatine BUN were normal. AST, ALP were also normal. So bilirubin total 64. The direct part of it was 13, both elevated. Bleeding indices were normal. MRDT, we repeated 2 times, it came back negative. HIV, hepatitis B and C were all negative. ESR raised at 60. PSA 100. And so he had a normal urine analysis. Also did the abdominopelvic ultrasound, which only showed enlarged prostate, no organomegaly.
Okay, let's go back to the labs. Okay, this is interesting. So, as I said earlier, uh, that with the fever, I talked about some possibilities, and then for obvious reasons, I prioritized infections. Now I think the job that I have is to see. So with I'll start with the CBC. So this CBC is very dramatic. So just 2 weeks ago, someone had a hemoglobin of 10, which of course is still anemic for a male. But 2 weeks later, the hemoglobin is 6.1. So with this massive decline in the hemoglobin, I think one thing, so of course there is a number of things that can explain what is going on. And of course, this is, that's why our job as clinicians is difficult, actually many times is difficult, because in any particular patient encounter that you have, there are so many things that can explain the presentation. So of course, it echoes those words that medicine is a science of uncertainty and an art of probability. So we work with uncertainty and probability, but with the data that I have, I think I'm very much inclined to think in the direction of hemolysis. So hemolysis is one of those things that can explain this very quick drop in hemoglobin from 10 to 6 in a matter of 2 weeks. And supported by that is the bilirubin, the total and direct bilirubin. So the patient's liver seems to be functioning normally. There is no transaminitis, ALT, AST normal. And then you see the total bilirubin is elevated, so more than 3 times actually the upper limit of normal. And it seems to be more of indirect, because the direct bilirubin is less than half of the total bilirubin that we see. So putting together this hemoglobin and the bilirubin direct and total, I am making an assumption that this patient is hemolyzing. The patient is hemolyzing. There could be other possibilities. I mean, such a quick drop in hemoglobin, of course, things like uh, acute blood loss can also cause that. So someone, for example, vomiting massive hematemesis or massive lower GI bleeding can also cause the hemoglobin to drop that fast. But of course, we in the history, in the physical examination, we did not find anything that was pointing us in that direction. So another thing is thrombocytopenia. So a platelet count of 32, again a very quick drop from from 200s just 2 weeks ago. So I think I'm prioritizing infections, but I should not throw out the possibility of other things like autoimmune disease, malignancies, maybe nothing very much in keeping with malignancies. Now, the next question that I have is, so if I am thinking infections, what infections can explain this picture? An infection that will cause hemolysis, an infection that will cause thrombocytopenia. So malaria can cause hemolysis, but the MRDT, which was repeated a number of times, was not negative. So I think I believe it was repeated maybe a number of hours apart, because that is the standard. So in a patient like this, you have to make sure that you try as hard as you can to make sure that malaria is completely ruled out, because malaria can explain hemolysis, and based on base rate, malaria is, although yes, the prevalence is going down, a lot of work has been done, but still, uh, we are still in a malaria endemic area. So I think it's still important to rule out malaria. So with an MRDT that is done, an MRDT a BS that is done 24 hours apart, maybe another one after another number of hours. If it's still negative, I think the possibility that we're dealing with malaria goes down. So other infections apart from malaria that can explain hemolysis, what are those? That's a tough question, because if we talk of thrombocytopenia, of course, if we talk of thrombocytopenia, we have infections that can explain thrombocytopenia. So arboviruses like dengue, for example, can explain thrombocytopenia. Not very commonly to cause to explain hemolysis with arboviruses like dengue, which is the most prevalent one. I think I should not completely rule out that possibility, but so that is one of the possibilities. But otherwise, I think I have a hard time to say that dengue, for example, can explain both thrombocytopenia as well as hemolytic anemia. So apart from malaria and apart from a distant consideration of dengue and other viruses, what are the infections? I think with infections, apart from the arboviruses that I've mentioned and parasites like malaria, other parasites that can cause or other infections that can explain hemolysis. So we have some spirochete infections, some of which are not endemic in our setting. So like limes. So limes have not heard or read about cases of limes in our setting. So spirochete infections, but again we have things like Q fever, Rocky Mountain spotted fever, scrub typhus, and other things like those that can cause hemolysis. But again, I've never come across those cases in our setting. I believe they do exist, but at least from reading and from practice, from observation, I've never come across those. So I think I'm limited when it comes to infections. I think I should put that to rest for now. Another possibility now is the hemolysis that we are talking about. Could it be autoimmune, for example? Yes, we do have autoimmune hemolytic anemias. But then, and I think we should entertain that possibility. But now, based on the history, I think nothing else is pointing me in that direction. But I should also include that possibility that this could be autoimmune. And then, if you see hemolysis, and then you see thrombocytopenia at the same time, a microangiopathic hemolytic anemia is worth considering. Microangiopathic hemolytic anemia. So you have things like TTP-HUS, and so there's something that is against those two specifically that I've mentioned. There is nothing in the kidneys are completely fine. The creatinine is normal, the BUN is normal, urinalysis is bland. So so something like TTP-HUS may be not very likely. So there are other autoimmune hemolytic anemias. So something like Evans syndrome. So Evans syndrome, you have autoimmune hemolytic anemia. You also have thrombocytopenia. So that's another thing. But then I think epidemiology is probably against me, because again, when you talk about autoimmune diseases, we talk more commonly in females, but again, males are not completely exempted from those. So I think with infections, I have some possibilities, and then autoimmune hemolytic anemia, but then I should try and qualify it that we are probably dealing with that should be something like Evans syndrome, for example, because there is both hemolytic anemia and then there is thrombocytopenia. Another thing is this could be hypersplenism, but then I do not remember. I think Joseph presented an abdominal pelvic ultrasound. Yes,
Yeah.
physical examination can miss splenomegaly, but a well-performed ultrasound will not miss splenomegaly. So, because this patient has been drinking heavily for a number of years, we could think maybe there is portal hypertension, splenomegaly. So they enlarge the spleen, sequesters the red blood cells, sequesters the platelets, and destroys them. But the abdominal pelvic ultrasound was normal. So hypersplenism, I think, is very far-fetched. And if we choose to trust the sonograph, I think it's not a possibility in this patient. The ESR, the ESR reinforces my assumptions initially that this patient is inflamed. So if the patient is inflamed, we are talking of an infection, an autoimmune disease. I've discussed those possibilities. Malignancy, so far, I have not found a malignancy that better explains the patient's symptoms. So I think I'm still lost, but made some progress. That the patient's symptoms, the patient has a hemolytic anemia, the patient has thrombocytopenia that has been picked by the labs, and other labs so the bilirubin direct and total are supportive of that the patient is probably hemolyzing, and the ESR tells that the patient is inflamed, and then the PSA that is elevated, this patient has BPH, so an elevation in the PSA is not very surprising. A prostate malignancy, for example, are we dealing with a prostate malignancy? I think a prostate malignancy would not explain all of the patient's symptoms. So things like weight loss, and yes, when we talk of fevers and night sweats, they are more common with liquid malignancies or blood malignancies like lymphomas and leukemias. Less likely, but still possible with solid malignancies, prostate malignancy being one of them. But then again, with the ultrasound, maybe there would be some suspicious features. For example, apart from just reporting enlargement, maybe there would be other things like calcifications. The prostate looks heterogeneous. And then maybe we would have some other features in the labs that would make us suspect that we are dealing with the malignancy. So I think with the prostate, we are probably still dealing with something benign rather than malignant. So that's where I am, Joseph. I'm not sure if you have anything else for me.
Yeah. So yeah, that's a pretty good discussion of the labs, explaining them. Hope people are taking notes. Yeah. So we did for the lab. We sent home tests, which came back negative. We gave this patient 60 milligram of prednisone and 1 unit of factor ABC that was available. But one day later, we controlled this HB and it went further down, 5.8.
Okay, so let me just go back and present the problem again and see what is going on. So we are very sure that there is hemolysis happening with this patient. Now let me take time. I know I've already taken a lot of time discussing what is going on, and this is because I'm not sure what is happening. Now let me take time to discuss hemolysis and see maybe there's something that I am missing. So red blood cells. So when we are talking of hemolysis, it's there is destruction of the red blood cells. Now the red blood cells can be destroyed as a result of a number of things. So there's something wrong in the environment. So in the bloodstream where they are swimming, there could be something wrong with the environment. So that is extracorpuscular. And with this one, I've talked about some possibilities like microangiopathic hemolytic anemia. So you have a problem with endothelium. There is endothelial damage. The RBCs are passing through the blood vessels and they are destroyed by shear forces in the endothelium because it's supposed to be smooth. So that is something extracorpuscular. Microangiopathic hemolytic anemia, so just so the hemolytic anemias that are happening because of things outside the RBCs themselves. So I mentioned some possibilities, TTPHUS, which the kidneys are betraying us. So, and that's good news for the patient because so things like TTPHUS carry with them a degree of mortality. So that's good news for the patient that the kidneys are spared. So other things are like DIC, but then we do not see a picture of DIC in this patient. Um, so other things are like autoimmune hemolytic anemias, and autoimmune hemolytic anemias, it can be, I should say, I'm not sure if that is the right term, but primary autoimmune hemolytic anemia or idiopathic. So it happens on its own. So with hemolytic anemias, you basically have antibodies against the RBCs. And that's why a Coombs test is performed. And Coombs test is negative for this patient, but we still have Coombs negative autoimmune hemolytic anemia. So that is a possibility. So another thing is you can have autoimmune hemolytic anemias in association with other autoimmune diseases like SLE and many other autoimmune diseases that you know. But so with this particular patient, we do not see other features of autoimmunity. I mean, apart from the hemolytic anemia itself, we do not see other features of autoimmunity. So joint symptoms, skin manifestations, oral ulcers, hair nail changes, anything of that sort has not been reported. So an autoimmune hemolytic anemia in association with other autoimmune illnesses maybe is not a very huge possibility, although for some patients, autoimmune hemolytic anemia can be the initial manifestation of systemic diseases like SLE. Yes, so for some, so of course I'm struggling. I mean, for me, maybe I would struggle to say maybe let's order an autoimmune panel like ANA and other things because I have not seen other things that are supportive of something like SLE, for example. So apart from the autoimmune hemolytic anemias that I've discussed, another thing could be that you have you have hemolysis as a result of something that is inherent in the red blood cell. So you are talking of things like abnormalities. Now you are talking of something inside the RBC like a hemoglobinopathy. So we know sickle cell disease is prevalent in our setting, but then we are dealing with a 61 years old male. Not very likely that sickle cell is starting to present for the first time in this patient. Hemoglobinopathies, membrane abnormalities like spherocytosis, elliptocytosis, maybe again not very likely. But what I would do for this patient, because the patient is hemolyzing, because the patient is having thrombocytopenia, I definitely need to order a peripheral smear, and a peripheral smear can answer some questions. So I think a peripheral smear is one of the next steps for this patient. So I'm saying this because the patient is an alcoholic. So I'm just trying to think about some things. You know, alcoholics can be malnourished. Alcoholics can be malnourished, and because of being malnourished, they because they are not taking inadequately, they can have some micronutrient deficiencies, including vitamin B12 and folic acid. And of course, so commonly, if we are thinking about megaloblastic anemia, we expect to see the MCVs elevated. But then what if there is a combination of iron deficiency and folate or B12 deficiency? And I've read about cases of someone with B12 deficiency, that was pernicious anemia specifically, who presented with a hemolytic picture. So I think for this patient, I also need to order B12 as well as folic acid. And another thing, because I was discussing the issue of alcoholics, I've read about alcoholics actually having some abnormal RBCs. I think again it's because of the nutrient deficiencies. So you are talking about abnormal red blood cells. So something in line of spherocytosis, for example, because of alcohol. And therefore these RBCs are destroyed and you end up with a hemolytic picture. So all these are other possibilities, but I'm not exactly sure now what is happening with the patient. Apart from that, of course, we have other things which you have abnormalities in some proteins on the surface of RBCs. You have paroxysmal nocturnal hemoglobinuria. I think that is not very likely with this patient.
Mm.
So yeah, so hemolysis, I mean, apart from infections, I've discussed about some infections which should be prioritized in this patient. I'm still thinking of autoimmune hemolytic anemia, particularly, of course, Evans syndrome, because there is thrombocytopenia also. But I think those other things like the effect of the alcohol itself, leading to hemolysis, and then micronutrient deficiencies, including B12 and folate, leading to the same picture. So I think all those are also possibilities. So I do not have a diagnosis yet. The umbrella diagnosis is we are dealing with a hemolytic anemia. Now, what is the cause of, what is the exact cause of the hemolysis? I do not have an answer. But the next things that I would like to do, a peripheral smear, B12, as well as folate. So that's what I have, Joseph.
Yeah, David, that's true. This was a tough case, and so that the fact that Coombs' test of this patient was negative, does that change anything in your what you're trying to say as far as diagnosis is concerned?
Yeah, so I do not remember the exact percentage, but then I think, yeah, most if we are talking of autoimmune hemolytic anemias, most of them are Coombs positive. So I think I should say maybe at least 5% of autoimmune hemolytic anemias can be Coombs negative. I do not remember, I should not be quoted. I do not remember the exact percent, but there is a subset of patients with autoimmune hemolytic anemias with Coombs test being negative.
Sure. So this patient requested transfer to another hospital, so we gave it to him. I received information from his brother who said at that hospital he received multiple blood transfusions, and he was diagnosed with prostate cancer, with met to the bladder and bones. But as far as I questioned that blood, I said the cause of anemia in that hospital and thrombocytopenia was not established also. So it was discharged from that hospital from I think 1.5 or 2 weeks, and he died home suddenly a few days after being discharged from the second hospital. Do you have anything else, David?
Okay, yeah. What is so of course I think with this one I'll take time to talk about the diagnosis of prostate CA. I'm not exactly sure what modalities were used, and of course, uh, so I based on the ultrasound results, I think I threw out the possibility of prostate CA, although a malignancy was one of the differentials that I was considering. So the top three differentials, apart from infections, autoimmune, and then malignancy. But then I think I banked on the ultrasound, and because it did not report any features that were in keeping with the malignancy, like I said, calcification or maybe a heterogeneous appearance. So that made me think lowly of prostate malignancy. But then, of course, the I think with the PSA was markedly elevated,
Mm.
and therefore, yes, I think in retrospect, I think, of course, that was important to be investigated further, just to make sure that we are not dealing with the malignancy. But then now the question comes: mets to the bladder and mets to bones. The urinalysis was bland, so mets, of course, we are not exactly sure where exactly in the bladder, but then so nothing like even microscopic hematuria in the urinalysis. So we are not exactly sure about the mode of diagnosis, but of course, if a diagnosis was made, probably by advanced imaging like CT, or maybe they did biopsy. So all those are possibilities. But now the question is, does prostate CA explain the hemolytic picture that we see? Nothing that I am aware of. Nothing that I am aware of. And I did not see anything else in the labs that was pointing us in that direction. Of course, because the patient did not have any musculoskeletal complaints, no imaging was obtained, because maybe if we did, if x-rays were done, for example, bones where the patient had complaints, maybe we would have picked some osteoblastic lesions. I do not remember you presenting calcium, but maybe serum calcium would have given us an idea. But so otherwise, still, even with the diagnosis of prostate CA, I still do not see a way that it can explain the hemolysis. I do not know enough to say it's not a possibility, and that's why I'll just sit back and learn from you on what you went and read on, and maybe came up with something. So of course I do not have a diagnosis up to that point. Just that we are dealing with the hemolytic anemia and thrombocytopenia, but what exactly is causing this, I do not have an answer.
Yeah, you're not alone, David. So this case has been in my mind like for 3 or 4 months. I saw this case, I think the last year, and I was thinking of it like every other day, trying to see what was it. But yeah, so I have some possibilities in the same lines as you. So let's see, because yes, at the end there is no definite diagnosis. There is no final diagnosis. No one knows, because the only chance that this patient had to identify what was the cause of this anemia was at that hospital. It's a big hospital, and so when I questioned them, I realized, as you clearly said, they needed a peripheral smear to see what was happening. So yes, you said TTP, and I thought of it, but in diagnosing TTP, you have to send what is called Adam 13, and so Adam 13, even in the advanced countries, it takes weeks to come back. And it's a fatal diagnosis, so you have to treat it. So they designed this called plasmic score. If you score a patient and they score high, you just treat them while waiting the Adam TS13. But if it is intermediate, you weigh should you give or not. But if it is low probability, less likely. So I did add plasmic score of this patient, as you are seeing on your right side. It came back 4. There was hemolysis, MCV was less than 90, INR was normal, and creatinine was normal. So there was a low probability. So probably this was not TTP, not 100%, but less likely. Another thing, as you clearly said, Shiga toxin, hemolytic uremic syndrome. Yes, AKI has to be there. It must be there. AKI has to be there. And usually, more common in kids less than 5 years. But usually, that's why it's called a Shiga toxin HUS. There is a preceding Shigellosis diarrhea. which was not there in this patient. Evans syndrome, truly, I also considered it as we are saying, but Evans syndrome, as you've correctly said, is a combination of immune thrombocytopenia and autoimmune hemolytic anemia. So you have to have a Coombs positive in Evans syndrome. And again, they respond to steroids. I've seen few cases of I've never seen Evans. I've seen autoimmune hemolytic anemia. You give them steroids, next day HB goes up. It's very nice. You give 60, it goes up. So also this was not the case. So what was it? After this patient was diagnosed with advanced malignancy of the prostate, I had to consider what is called a cancer-associated thrombotic microangiopathy. David, you are very right. You said as you're seeing thrombocytopenia, intravascular hemolysis, you think of MAHA, and TMA is a part of MAHA, in which there is MAHA plus thrombocytopenia. So why do you consider cancer-associated thrombocytopenia, cancer-associated thrombotic microangiopathy? This because first there was no response to steroids. Number two, he had advanced prostate CA. Number three, very high mortality without treatment of the underlying cancer, which happened to this patient. After like 2-3 weeks from hemolysis, patient died. So I have some few teaching points. This is not the final diagnosis, the definite diagnosis. That I don't have anything, but it's what I'm trying to think, and that's why I brought it here so that we can learn. Maybe you can disagree with me, it's okay, but this is what I am. So yes, David, you have said this. MAHA is when you have a Coombs negative intravascular hemolysis that produces schistocytes on peripheral smear. So if they could have done peripheral smear in that second hospital and they saw schistocytes, we would have very high likelihood that we are dealing with a cancer-associated TMA. But they didn't do this, or maybe because they told this guy is a bit medically educated, that we don't know what is happening with the anemia. So he could have told me. Thrombotic microangiopathy is when you have microangiopathic hemolytic anemia plus thrombocytopenia. This patient, this was the case that he was having. So what happens is there is abnormalities in capillary walls, which leads to microvascular thrombosis. And then when the RBC passes in those destroyed small vessels, they are being slashed off. When they are slashed off, they make the schistocytes that you can see them on peripheral smear. So if one day you see a peripheral smear reporting a schistocytes, just know that they are talking about microangiopathic hemolytic anemia. So most commonly, you have TTPHUS, drug-induced, but there are others. And these others include preeclampsia. You all know about HELLP syndrome, hemolysis, elevated liver enzymes, and low platelets. And then severe hypertension, cancer, which this patient had, autoimmunity like SLE, catastrophic APLS, antiphospholipid syndrome, and then infections. If you have infections, you go into DIC. You can also have a picture like that, but this patient, the bleeding indices were pretty normal. So a bit on cancer-associated TMA, which I found fascinating. This is very rare, but it's very serious. It kills patients. So what happens is that the cancer cells, they invade the small vessels, the capillaries, and they cause endothelial damage. What happens after that is embolism in those small blood vessels. And that embolism, when the RBC passes, it slashes them off, causing hemolysis. Most common cancers include lung cancer, breast cancer, gastric cancer, and prostate cancer. To treat the things, what you have to do is treat the underlying malignancy as an emergency. So maybe you give chemo or radiation. What do you think, David? That's what I am. I don't have, like, I can tell you what happened, but I think this is what happened. Some of the things you mentioned, some I added them because those that you mentioned, I also thought of them, but I realized they don't tally with the patient as you are saying.
Thank you very much, Joseph. So, um I yeah, I mean, with all the time that you spent, and of course, I should say, uh, I should commend you, of course, first of all, for this is this is this is how medicine is supposed to be practiced. Like so, we say, I think many times we practice medicine by we like to take pleasure in the wins. A patient comes, you treat them, and they go home. Maybe they come back next time and they are happy because they are feeling better and you are happy as a clinician. But then uh, feedback is what helps people improve. Sometimes you treat someone or you make a diagnosis, and just like I said, we are dealing with uncertainty and probability. Sometimes you treat them or you make a diagnosis and then you turn out to be wrong. So you learn that by feedback. For example, the patient comes back, maybe they did not improve on some treatment plan which you thought will bring about improvement, or they go to another doctor and then they come up with something else. And maybe if you are lucky enough, they come and you gather information and you see, okay, so I was wrong here, and this is how it's supposed to be done. So we do not learn from just the cases that we get right, but again, not just from the cases that we know. So you see what Joseph did. Saw a patient, the patient succumbed to the illness, but still many months later, still thinking what exactly happened with that patient. Because with that knowledge, the next patient that comes in, Joseph is better equipped to make a correct diagnosis and to treat them and maybe save a life. So kudos to you, Joseph, for doing that. It's a sad ending for the patient, but what you did has been a huge opportunity for us to learn. So, and the a new thing that I learned today. I mean, after you presented, sometimes we think about things we've never come across. So after you mentioned that the patient was eventually diagnosed with a malignancy, then of course something crossed my mind that, okay, can the cancer explain a microangiopathic hemolytic anemia uh, and the thrombocytopenia? But then I've never come across that. So even if I say that, maybe it would just be an intelligent guess. So I think that is new knowledge for me today. Cancer associated thrombotic microangiopathy. So thank you very much for the learning. Again, I think it was a very huge learning opportunity for me. So to review some things like hemolytic anemia and all those other things. And I think for those who have joined us for the very first time today, you've seen how real life cases can be. So something that started as easy fatigability, and then you've seen all the twists and turns that it took all the way to the time where we do not have an exact final diagnosis, but we are still trying to see what exactly happened. So that is the kind of medicine that we practice. It's not always simplistic that you see a patient, take a history, do physical exam, order labs, you are able to perfectly interpret them, you start treatment, the patient recovers. It's not always that simple. So that's the reason we do what we do. So thank you very much, Joseph, for the opportunity. I think I learned a lot from what I do not know. Thank you very much.
Yeah, thank you for discussing. Thank you, Roland, for the comments. Some learning points from you there. Anyone with anything else before we close the session? Yeah. So if
Yeah,
nothing,
so I see there are no comments today. So the audience was bigger than average. I think Joseph, you've seen that.
yeah, sure.
Yeah, so there are new colleagues who have joined us. So I believe many of the new ones are first year residents. So I shared the link with one of them who has been so Jelemanus has been joining us for a number of weeks now. So I think he's the host for his colleagues, and so I shared the link with him today because they are done with their basic sciences. I requested him to share the link with them. So I think uh, of the newcomers, I think most of them are coming from that pool. So I would like to take this opportunity to welcome you very much to this platform. So as you saw the name, we call it Afro DX, and what we do is we discuss cases, very commonly real life cases that we see in our setting, and of course Joseph is leading. He's the one who has presented the most cases, I think, on this platform, the cases that he has attended, and we get to learn from those cases. So you are very much welcome. Maybe uh, this might have been a new style of learning for you because it's not commonly done, especially in our setting. But that's how we do it. We do this because we recognize that clinical expertise, especially when it comes to diagnostic reasoning, management reasoning, although we read from books, but then uh, real life cases are not exactly presenting as the way we read in books. And even those people who are trying to systematize knowledge have always found it difficult. You can be taught chess by learning, by reading in a book, but how to reason diagnostically is something that is still puzzling many people who have tried to even performance psychologists. So the best way we have so far is what we do. So a think out loud protocol. You listen to someone, and they as they think through a case, so you get a thing or two to learn from them. So that's why we chose this modality, because we thought it will challenge us and it will help us grow. So this might be the first time it's new, but we hope you will get used to it. And you are very much welcome. We meet here mostly on Sundays at 8 p.m., just like today. So we'll keep sharing the link. Feel free to join, and we hope to get discussants from you. And because we'll be seeing cases, uh, so you also very much encouraged, if you come across a case that you think is very interesting and people can learn from it, just summarize it, and you can reach out to me, you can reach out to Joseph to present your case. If you want to discuss a case, you are more than welcome to do that. We are very happy to have you on the platform, and we look forward to having you always.
Yeah,
So,
karibuni sana.
so if there's nothing else, I think we meet next weekend. Have a good night, everyone.
Good night.